Welcome, everyone. This is Sari Schumann, and let's go ahead and begin our webinar. Welcome to the Alzheimer's Disease Supportive Services Program Grantee webinar, facilitated by the ADSSP Resource Center, which consists of RTI International and the Alzheimer's Association National Office. I am, again, Sari Schumann with the Alzheimer's Association National Office in Chicago, and I'll be moderating the webinar today. Our ADSSP National Resource Center team also includes Liz Gould, Josh Weiner, Jan Mayer, Kate Gordon, Patty Ewan, and Katie Maslow as an advisor to the project. As a reminder, the purpose of these grantee and partner webinars is to provide helpful, current, and applicable information for your various grant projects. Please note the webinar today is being recorded. I'd like to turn it over briefly to Erin Long for a welcome.
Good afternoon, everyone. Thank you so much for taking the time out of your day to join our webinar. We are very appreciative of Katie Maslow and Sheila Molony's willingness to share their knowledge with us, and we'll just turn it right over. I'll turn it back to Sari to start things off.
Thank you, Erin. At this time, I'd like to introduce Katie Maslow of the Institute on Medicine and Sheila Molony of Connecticut Community Care. Ms. Maslow today will speak to us about the background and unique concepts of person-centered care for people with dementia. And Sheila Molony will provide information about person-centered care coordination for people with dementia. As you probably are aware, if you've been on one of our technical assistance events before, we will wait till the end to have questions. And at that time, or during, if you'd like to, so you don't forget them, you can type those questions into the chat function that was introduced to you a few minutes ago. So without further ado, we'll send it over to Katie Maslow to start off our presentation.
Thanks, Sari. As Sari said, Sheila Molony and I are going to be talking about person-centered care for people with dementia. Our remarks are based primarily for me, and I think in part for Sheila, on work that we did for an issue of Generations. As you probably know, Generations is the journal of the American Society on Aging. The issue on person-centered care for people with dementia came out a few months ago and is available for anyone to look at further. We hope that as a result of this webinar, you will understand the origin and current status of person-centered care for people with dementia in the U.S., understand the key concepts and their implications for care systems and service providers, and key components of person-centered care coordination, which Sheila will talk about primarily. Person-centered care for people with dementia had its origin in the 1980s in England. Tom Kitwood at the University of Bradford observed and was very disturbed by derogatory terms and images that he heard used to describe people with dementia. Terms and images that suggested that these individuals were no longer people, no longer persons, and that they had lost their value as human beings. He and his colleagues at the university then began to think, speak, write presentations around the world about what they had observed and ideas for improving care. At the same time, dementia care providers and researchers in the United States, in Canada, Australia, and other countries had similar insights. And over the past 25 or 30 years, they have developed and refined the key concepts of person-centered care for people with dementia and approaches for a different kind of care. Kitwood called it person-centered care for people with dementia or person-centered dementia care. I'm going to make a distinction now between what Kitwood called person-centered care for people with dementia, and a different movement that's gaining a lot of momentum in the United States right now that you are probably aware of. I'm going to call it patient-centered care. It's sometimes also referred to as person-centered care, which makes it confusing. The terms aren't important. The important thing is for you to understand the difference between these two movements. So patient-centered care is a movement that is strongly supported and pushed now in government programs, in private sector programs. It's widely acclaimed as a means and a goal in improving care for people of all ages with various conditions and care needs. So it's not just for people with dementia, although it certainly could include them. And the strong emphasis in government and private sector programs on what I'm referring to as patient-centered care offers possibilities and opportunities for improvements in care for people with dementia. It's been defined by the Institute of Medicine as care that is respectful and responsive to individual patient preferences, needs, and values, and ensures that patient values guide all clinical decisions. You can see that that would be positive for people with dementia, but in these two similar but not identical movements, there's a lot of potential for misunderstanding in the context of dementia care. I'm going to give some examples later on, and the reason I'm talking about this at all is because you may see these two different things in the settings where you work, and I think it's important to understand both what the two are and the potential for misunderstandings. So going back now to the person-centered care for people with dementia as envisioned first by Tom Kitwood and other dementia care providers and researchers. So perhaps the most important concept underlying this kind of care is this concept that each person with dementia is unique. On the one hand, that's sort of a philosophical or ethical statement that I think is obvious to all of us. On the other hand, many people in our society have one stereotype or perhaps two stereotypes that come into their minds when they hear the words person with dementia. And these stereotypes have very negative impact on their views of people with dementia and on the kind of care that they can envision providing for people with dementia. I'm sure you are aware of and can think of probably many more than I can, ways of in which people with dementia differ. Just some examples. They differ in the disease or condition that's causing their dementia, its stage, their age, their health, their coexisting medical conditions, race, ethnicity, culture, education, life experiences, family. I could go on and on with that. But obviously, these differences make it clear that they have different care needs, that they are extremely heterogeneous, and that they are rarely, our services are rarely appropriate to meet all of those needs, the different needs of individuals. So for care systems and service providers, this means that we need procedures and time, and I'm going to be talking about time several times in this presentation. We need procedures and time to learn about each person with dementia, and we need that array of services to address individual situations and care needs. A second concept that's closely related is that the person or self continues to exist despite the loss of cognitive abilities. This is a concept that directly contradicts some of the negative stereotypes that Kitwood and others noted. For example, stereotypes that the self is lost, or sometimes it's said that the person with dementia is an empty shell, or with dementia are referred to as the living dead. Obviously, these kinds of terms and images are often used to refer to people in the very late stages of dementia. But stereotypes that are widely held in our society don't necessarily take these stages into account. So I'm sure that you can imagine the impact on the person with dementia if he or she hears and understands these kind of terms, but perhaps even more so the family, any other caregivers, paid or unpaid, and people who will develop dementia. The terms and images are frightening, demeaning, and so on. For care systems and service providers, the important points are that we need to develop an organizational culture or organizational cultures that counter the stereotypes and negative images. Most importantly, I think we need to provide training and learning experiences for staff who will work with people with dementia to help them see and understand the continuing self or personhood in people with dementia. When we were working on the issue of generations on this topic, I think that this idea was probably the most frequently and intensely repeated one throughout the 19 articles in the issue. That is, finding ways to help staff learn and experience understanding of the uniqueness and the continuing self or personhood of an individual with dementia. A clearly related concept, the person with dementia has remaining strengths and non-cognitive abilities. This is another philosophical statement that's probably obvious to all of us. But I wonder, maybe it's difficult for some of us to really believe or to understand implications. So we live in a society that's highly cognitive, and to truly understand this concept of non-cognitive abilities and remaining strengths can be difficult. And certainly, I think it's true that many of our care systems and service providers do not routinely assess individuals with dementia for strengths and non-cognitive abilities. For care systems and service providers, there's a need to expand staff perception of dementia to include strengths and non-cognitive abilities. There's a need to create assessment procedures and, again, time for staff to learn about the person's strengths and non-cognitive abilities, and then a need to provide training about care planning and service referrals that build on strengths and non-cognitive abilities. I've mentioned time twice, and I will mention it again a couple of times, but I think that lack of time is one of the biggest barriers or perceived barriers to greater acceptance and implementation of person-centered care for people with dementia. Another concept, a key concept of person-centered care for people with dementia, is that these people can express values and preferences. Extensive research that you are probably aware of shows that this is true for people in the early and moderate stages of dementia, and that their expressed values and preferences are generally consistent over time. just like the values and preferences of people who do not have dementia. So those are significant findings of, in the literature which support this person-centered care approach. For care systems and service providers, there's a need for procedures and, again, time to learn about the person's values and preferences. There's a need for training and here experiential learning for staff about how they can learn about the values and preferences of people with dementia. This is the first area that I'm going to mention where there's potential for misunderstanding in the context of the movement for patient-centered care and thinking about people with dementia. In that patient-centered care movement, there's a very strong focus on providing care that's responsive to the values and preferences of the person, which is wonderful. However, if service providers, healthcare providers, or community providers believe that people with dementia cannot express their values and preferences, they may then believe that patient-centered care won't work for those people, that it's not appropriate for those people. So that's a problem and a potential area of misunderstanding between the two movements. A final key concept that I want to mention is relational-centered care or relationship-centered care. I think we're all aware of the substantial hands-on and other help that's provided by family caregivers of people with dementia, and similar kinds of help that's provided by other paid caregivers. This concept of relational or relation-centered care is different. The concept is that hands-on and other help are provided in a relationship, and the relationship itself can support or undermine personhood and functioning in people with dementia. To me, this is one of the most difficult concepts of person-centered care for people with dementia. It's difficult not as you first think of it, but for me it's difficult to understand exactly how it can be incorporated into care systems and services. Perhaps some of you have some ideas about that. In the issue of Generations, there's a great article about this relational-centered care by Darby Morhart and Marcia Spiro. I found it very thought-provoking, and I recommend it to you. I want to mention three more areas where there's this potential for misunderstanding between the two movements. So I mentioned earlier the potential for misunderstanding about whether and how people with dementia can express their values and preferences. In patient-centered care, there's also a very strong emphasis on patient autonomy, and that emphasis on autonomy can result in questions about how care systems and service providers can and should work with families. So is it a violation of autonomy, of patient autonomy, for a service provider to be working with the family? How should that those two issues be addressed? I think Sheila is going to talk maybe a little more about that. Secondly, in patient-centered care, there's a very strong emphasis on patient use of information to self-manage, that is, to manage their own care, which, as you know, is difficult for most people with dementia and impossible for some. So in this situation where there's that strong emphasis on self-management, that idea can result in questions about if and how people with dementia can be involved and can benefit from patient-centered care. And then lastly, a strong emphasis in the patient-centered care movement on quality measurement that's based on patient-reported experience of care. That again, results in questions about how to measure quality of care in people with dementia who may not be able to report their experience of care verbally. So I've gone quickly over some material that includes concepts that are familiar to you, some that may not be familiar to you, and try to tie those concepts to important issues for the care environment for care systems and service providers. There's much more information and discussion in the issue of generations. It includes articles. Sheila has an article on care coordination, which she's going to talk about, and other articles talk about care for people with dementia in different stages, in different care situations, home, residential care, primary medical care, hospital care transitions, and so on. And there is also one article about suggestions for training about these key concepts and their implementations in various care settings. So I'm going to stop now. I'll be happy to answer any questions later, and Sheila is going to talk about patient-centered care coordination for people with dementia. Sheila?
Thank you very much, Katie. Thank you for that. And I want to echo and second your comments on the value of this issue of generations. I myself, in reading the many articles, learned new things that I did not know before, learned about some new evidence-based programs that I'm anxious to put into practice within my own organization. So I'm very appreciative of the author's efforts in this issue. First, I want to talk about key components of person-centered care coordination, and some of these will echo some of the points that Katie was making, and they will inform potentially some of the training materials that we would want to use. The first and foremost, of course, is valuing the person and demonstrating high regard. And this is a core value for all care coordination, not only for persons with dementia, but particularly important for persons with dementia because frequently they encounter healthcare providers, direct care workers who do not demonstrate high regard. So the care coordinator or care manager, through their role modeling of communication strategies, listening skills, being attentive, and the way that they speak about the individual demonstrates that value and high regard, and that's a very important component. Gaining trust is extremely important both for the individual and the family. And I agree with what Katie said. This takes time, ongoing contact, and relationship skills. Many times the care manager or care coordinator has difficulty even getting into the home to begin the relationship. So it has to be done very slowly, and the relationship has to be built over time. The best way to do that is through frequent or ongoing contact. We also use telephone and email communication with family members particularly and long-distance family members to have frequent communication about what is happening. One of the strategies that our care manager uses with persons with dementia is to attend primary care provider visits with the individuals. And what we find is that in the waiting room of the primary care or medical office, there's a lot of opportunity, a lot of time for chat and discussion and little conversations where you can pick up very important cues. At the same time, the care manager can speak with the physician, with the individual's permission, of course, and really reinforce the medical plan of care and have direct conversation with the primary care provider about things such as medication regimen simplification, for example. Listening and observing are really key skills. That's how the care manager learns what really matters to an individual at a particular point in time. I find that when I do visits or conduct assessments, I'll be chatting with someone, and they'll be responding, and we will be going through an assessment. And once I get to a question that really hits upon something that matters very much to the individual, their eyes light up. And you can immediately tell that you've hit upon something that's a little bit more meaningful than the other things you were discussing. And so it's important that I take the time to explore whatever that is. For some individuals, it'll be a discussion about a beloved pet. For other individuals, it'll be a possession that they have there in the room with them that they want to tell me about. It's something different for everyone. But that's very important, the listening and the observing what is important. Sometimes to figure out what's important or what matters, it takes a little bit of trial and error. You have to try something out. One of our care managers learned that an individual valued church, and she discovered what church she had gone to. She hadn't been there many years prior. She arranged for a companion visit to bring her there the following Sunday, and she described the experience as the woman was almost giddy. She was so happy to be back in the company of her friends and colleagues in the church. So that clearly was a good intervention. Sometimes that doesn't always turn out, and we have to use trial and error. Believing in individuals' capacity for success and well-being is extremely important. We often find that in the healthcare arena, there is sometimes pessimism about that, and that individuals will not do well or be well. So again, it's important for us to role model that. And then finally, to take action to support well-being. Even if we do a very comprehensive assessment and we learn what matters to individuals, it won't help unless we take ongoing action to try to do something with that information to support well-being. Care coordination for individuals living with dementia requires advanced skills. It does require the care manager or care coordinator to have ease in unstructured settings, to be able to tolerate uncertainty, to be very flexible and creative, and of course to have dementia-specific knowledge. I've had to work with neighbors who were providing support for individuals and have them make the introduction that would allow me to get in the door. Sometimes we use creative strategies to improve safety that have to do with shut-off mechanisms on stoves or ovens that can be turned back on when there's a supporter or care partner present, so that the individual could be engaged in cooking of some type, but with the appropriate support. So those are just a couple of examples in terms of trying to be creative, and I'll share a little bit more later in the case study. It's important. Dementia-specific knowledge is very important because care managers and direct care providers need to know, for example, that losing the ability to walk may not be consistent with a particular stage of dementia, and in fact it indicates a really serious illness or a potential symptom of a serious illness. In the issue of generations, there was a wonderful program described called Skills to Care, and I think that is one of the evidence-based programs where more skills can be brought into the home and to the direct care providers. So that's an important resource. Training that's needed to provide person-centered care for persons with dementia encompasses both of those areas. The person-centered philosophy and values, first of all. It's very important that that be conveyed and repeated over time for the individuals that are going to provide this type of care coordination. In our discussions about philosophy, we talk about person-centered care, but understanding that the person lives in a particular context. They live in relationship. They live in relationship to time. They have a past, a history of experiences that shape their current worldview. They have recurring rituals and rhythms, seasonal, cultural, and personal rituals and rhythms that might be very important to them. They also live in the context of the physical world, the body, the sensory experiences, and then spatial experiences that are associated with the built environment and the natural environment, and that can be very important. We need to assess that person's relationship with the environment. Some individuals have had improvements in quality of life just by increasing their exposure to nature, for example. Individuals live in the context of a social world, of groups and friends and communities and partners, and then the psychological and the spiritual world, and their own sense of meaning and purpose and their own sense of self and their own story and narrative. So when we talk about person-centered, we don't mean the person free of any other context. So I think that's important to the philosophy. The person-first language is important, and we often do, we just sort of do a little friendly check on ourselves and on each other to make sure that we're not leading our conversations with a diagnosis, a condition, a stage, or a case-based language, but really that we talk about persons living with whatever the challenge may be. In our own documentation, we use individuals' names rather than referring to individuals as clients, patients, etc. We try to use the person's name. We have found that that brings the individual who's doing the documentation into the individual's world in a very real way, and it changes the tone of the documentation. Of course, relationship and communication skills, education about self-determination and strengths-based care planning, working toward meaningful activity and engagement, case-based problem solving, and then recognizing cognitive impairment in the first place. That's a very important piece of the training. Our care managers are trained in using cognitive screening instruments because we know that if they don't do some type of a little bit of formal screening assessment, we sometimes miss individuals that have cognitive impairment. We had an example of that. One individual had gone through more than 50% of a visit and an assessment and did not seem to have a cognitive impairment, but when the care manager administered the mini-cog, they discovered a tremendous amount of difficulty with clock drawing, and that has sometimes have a correlation with challenges with medication management. So that was an important piece of the assessment. Differentiating delirium, depression, and dementia is a very important part of the curriculum, and being able to recognize early warning signs of illness that might decrease function. Preventing excess disability, anticipatory guidance and risk mitigation, of course, is a key component of care coordination and care management. Decisional capacity and surrogate decision making and coaching proxy decision makers and helping them to make those decisions based on what the person's values are rather than necessarily their own, and then planning to try to reduce avoidable hospitalizations. In care coordination and care management, we recognize the impact of the physical environment, the social environment, the healthcare environment on that individual's well-being. Some of the homes in the community that we go into can be very isolated and isolating, and so we need to try to bring resources and supports to try to decrease that sense of isolation. Some environments can be stressful versus comforting, so it's important that we pay attention to the physical environment and the social environment and what impact that's having on the individual. The caregiving environment, of course, is at the heart of care coordination. We have family members and care partners that are trying to do their very best to support the individual living with dementia. And it really is challenging to try to educate and work with the families and have them be on the same page with the individual living with dementia, and have all of us together working on walking the tightrope between being too safe and too much risk. One of our care managers said, yep, on that tightrope, you need a big stick to balance you with lots of supports on either side. There are winds blowing, and it's a very dynamic process. I would concur with that. In terms of formal caregivers, we agree that continuity in caregivers is preferred. It is not always possible in home and community-based services, but certainly preferred. And then the training and the skill level of the direct care providers is also important. Sometimes you have a personal care assistant or a home health aide or a companion that has just a very good chemistry or relationship with the individual and becomes one of the strongest advocates and a real asset to the plan of care. So we try to nurture that and maintain that type of continuity. And then, of course, adult day health centers can be a tremendous resource for caregivers and as a supplement or a support to the plan of care. And a colleague of mine recently was talking about wanting to start an adult night health center. So I look forward to that. I thought that would be a useful innovation. Medical care environments, I mentioned that our private care management folks often go to physician appointments with individuals. We also do that in our care transitions program, and we have found that to be very useful. We try to help people stay out of the hospital as much as possible, of course, and recognize that there's a risk for iatrogenic harm, meaning harm that comes about because of the medical treatment or as a result of the medical treatment. And so we're alert for issues related to polypharmacy and also under recognition of symptoms and illness. So at the individual level, we talked about some of the strategies that are important for care managers, identifying preferences that are expressed in behaviors or words, or sometimes the preference is expressed by looking at the home environment and the individual's possessions and some of the things that are meaningful to them in their space. We try to identify the topics, the places, and the relationships that bring comfort. And by focusing on some little things, little experiences sometimes, it builds that trusting relationship. And it is that ongoing building of trust that makes it a little bit easier if once we get to sort of touch point decisions, such as giving up a car or moving to a higher level of care. It's important to have that trusting relationship developed already. Maintaining opportunities for accomplishment and contribution and self-worth. I think this is an area that we need to focus on more as we work as care coordinators with the direct care providers. And recognizing the ability of the person to be fully present in the moment and to participate in choices and decisions. As one of my colleagues was saying to me, the person may not be able to remember what they had for breakfast, but can be so very fully present in the conversation. And so that's important to continue to convey. At the family level, as we're trying to walk that tightrope of balancing too much risk and too much safety and providing education and resources, it's important that we use clear and concrete terms. Family members don't always know what we mean if we're just vague about risks. I read about some individuals using pictures or videotapes to show some particular scenarios that may occur, and that may be helpful. That is not something that I have done in my practice, but I would be interested in hearing from others that have used that technique. Supporting the family and understanding the disease, and not only the family members, but some of the other direct care providers often don't understand some of the mechanisms behind the disease. I do find it useful here many times to use both the Alzheimer's Association website materials and also some print materials with pictures of what's actually happening in the brain when there's a visual there, and that often helps with the understanding. And family members recognize that some of the behaviors are not intentional toward them. So there's a lot of education and a lot of support that go on there. And then, of course, we have to have backup plans. many times we will put an intervention into place that will mitigate one risk, and then another risk will then appear afterwards. So it's an ongoing monitoring. It's very dynamic, and we have to have the backup plans. We spoke already about, at an organizational level, sharing that person-centered philosophy and values. It's very important that we provide supportive supervision for the care managers and the staff that are doing this work. This is very difficult work. We all sometimes need to chat with colleagues or chat with our team to make sure that we are on the right track and that we've thought of the appropriate options and supports, and that we are there's some degree of consensus about what's going on, and people can feel that they can reach out for supervision and training. Sharing best practice with each other and what works, similar to building on the individual living with dementia strengths, we like to build on our organizational strengths. And then conducting outreach. We have a gatekeepers program in our state that trains community workers such as mail delivery carriers and others who commonly will see people who are in their homes, might be able to detect when there's a problem. So that type of outreach, as well as outreach across programs. We have a collaboration with our Department of Mental Health and the services that they provide, and we are doing some cross-training with some of our mental health providers and aging services providers so that we benefit from each other's expertise. At the policy level, including person-centeredness and dementia in required curricula for care providers would support some of these efforts. Identifying best practices in care coordination for persons with dementia. Many of the elements that I've spoken about so far are very much time-based. They do take a lot of time. So trying to find models that will enable, for example, physician visits within the model. We do that in our private care management practice and in our care transitions work, not always in our public home and community-based services work because of the differing models there and the differing types of practice. And then identifying quality outcome measures that include indicators of thriving. We're thriving is really the opposite of failure to thrive, so that sense of connectedness, attachment, meaning, giving of oneself, positive affect, stable weight, and positive function. That was described in an article in 2002 by Haidt, Tesh, Barba, and Quartz, the concept of thriving. I just want to share a brief case study, and then I will close. I will share the study of Mrs. G. She had a diagnosis of dementia, and the care manager was caught in between physicians and healthcare providers who felt that she absolutely could not or should not live alone, and the daughter and the individual, Mrs. G., who absolutely insisted that she would stay in her own home and continue to live there. Our care manager first met her in 2008, and she ended up living successfully in that home for up until about a year and a half or so ago. She, at first, didn't even know that the care manager was providing formal services with her. The care manager did what she described as hanging out. They would hang out together from time to time, and then the care manager gradually introduced formal services. She needed to do that in order to build trust and relationship, and also to learn what was important to Mrs. G. She did end up getting the companion that took Mrs. G to church on Sundays, and did end up going to some of the physician's visits with her. So began to learn a lot about her life story. Even if there aren't large chunks of time in every conversation, there are little bits and pieces that come out, and so you can capture that and learn about what's important. And the care manager also spent a lot of time by phone and email speaking with the daughter, and they worked together as care partners. Initially, the daughter was not involved in the decision-making at all, or didn't realize that she might need to be. But as time went on and Mrs. G's condition progressed, the care manager developed a greater relationship with the daughter, and they really worked together as care partners in supporting Mrs. G. Eventually, Mrs. G did move to an assisted living section of a continuing care retirement community, and they worked, the our care manager and the daughter worked to prevent her from driving. She had had several accidents, and they had a formal driving evaluation done. Once Mrs. G lost her car, she began to lose weight, and what they discovered through assessment was that she had been driving to a local cafe, and now that she was no longer doing that, she was sometimes forgetting to eat. And so we had to put in additional supports for meals and meal preparation. The care manager began to arrange visits in a favorite coffee shop where Mrs. G liked to go, and she would eat well there. It was a very social environment, and it gave the Mrs. G a real boost because all of the workers there knew her name and treated her like royalty when she was there. So it felt like a success as well in going there. The care manager also facilitated the relationship with a very person-centered physician. Mrs. G had not had a primary care physician. The care manager recommended one, and they worked together as care partners to try to have a simple medication regime that resulted in Mrs. G's well-being. I'm going to stop there now so that we have time for questions.
Thank you so much, Sheila and Katie, for your informative presentations. We have gotten a few questions in, and we will start our question and answers at this time. So if you have questions, you can enter them into the chat area that you see on your screen. The first question that came in, I was able to get the information of where to get the Generations article and issue. So I'm just going to give all of you that information in the chat screen right now, so you can have it. And then the next question that came in was from Lynn Corty for you, Sheila. She was asking, and actually from Annette Peterson, they both were asking about the article about thriving that you mentioned, and then the outcome measure that you mentioned about thriving.
Yes, there isn't an outcome measure for thriving. I have developed a slightly different outcome measure that is referred to as the experience of home scale, and that scale measures at homeness. And I can provide that reference. I may not be able to provide it just at this very moment, but I'd be happy to provide it so that it could be sent to the group if that works.
Yeah, that is fine. I can send anything out after the webinar.
Great. I can send both of those references. I'm going to take a quick peek in my Generations article to see if they were in the reference list there as well.
Okay. Well, while you're looking, Sheila, I'll skip one question that was directed toward you, and I think, Katie, you'll be able to answer this question we have from Stephanie Bates. Are there specific evidence-based interventions recommended? And the other part is for you, Sheila. So, Katie, could you answer that first part right here?
Well, you heard Sheila talk about the Laura Gitlin's intervention, Skills to Care. That's one. There are some interventions and some that may be actually being provided by some of the people on the call, but interventions that actually target the person with dementia, either separate from the family or much more often as part of the person and family caregiver dyad. So there are many interventions. I think that the importance of the person-centered care for people with dementia is really focusing on the wide range, large number of things that can be done for the person, and that we don't always focus on those parts of interventions or that kind of care. So I think I'm sure that you've heard in what I said and in what Sheila said, this a very large number of things that can be done for the person. And so I think that's the important area in thinking about interventions.
Thanks, Katie. Sheila, the next question was for you. I'm not sure if you had a chance to look in your article for that reference, but if it is in there, I can type it out if you tell me which reference it is.
It wasn't on that particular reference list, but I can send you those if there's a way to disseminate them.
Yeah, there is, so you can feel free to send that to me via email, and I'll get it to the group.
Okay,
the next question, sure, was for you. If you could explain the concept of excess disability.
Yes, I think that's a term that we use sometimes in nursing practice, which happens to be my area of training, and perhaps I shouldn't have used that term, but it means disability that is really more a function of the environment or the care environment, not disability that's related to the diagnosis or the condition. So, for example, if a caregiver is providing too much care or too much support and is not facilitating independence, they might be facilitating what I would refer to as excess disability.
Okay, thank you. The next question was asking about the model used to train the community members to recognize issues, for example, for the postal carriers.
Yes, that was part. I wasn't directly involved in the training. It was part of what we refer to as the Gatekeepers program, and it was a collaboration with our Department of Mental Health and Addiction Services, but I could certainly get more information about it.
Okay. Those are the questions we have at this time. Just if anyone else has questions, please feel free to put them in the chat feature that we have here. Does anyone who is connected by phone have questions? If there is anyone connected by phone, you can unmute yourself now and ask those questions.
If you do need to unmute your phone, all you have
Okay.
to do is press *6, and that will unmute your phone.
Thank you, Josh. And we have 2 other questions that look like they might be coming in a minute. So we'll just pause for a moment. So, Sheila, one question was, who is paying for Mrs. G's care management?
Good question.
Yeah, she was, in her case, she was in our private fee-for-service care management program, so it was family and private dollars.
Okay, and then to answer Donna's question, yes, Donna, I can send out the PowerPoint to everyone who is on the call or on the webinar. So I will do that. Are there any other questions that anyone has? Or any other comments from either Katie or Sheila?
I do have the reference here for Haight Barba Tesh and Courts, if that would be helpful. I can just type it into the chat myself.
Perfect. Thank you. And while Sheila's doing that, just so everyone notices, if you have questions after the webinar, you can direct them to me. My email address is in the closing notes section, and the email is ssshuman@alz.org, and I can get those questions to the appropriate people if you have them. And just an announcement then before we, while Sheila's typing and before we close, the next webinar, we're going to be skipping the month of March, and we'll talk again in April, on April 10th at the same time, 3 o'clock Eastern. And this webinar will be about providing services to people with young onset dementia. So we hope that all of you will join us for that. It looks like Sheila had a chance to put in that reference. And I will also be able to send that out with all the other information that I sent. So So I don't see any other questions coming in. So I want to give a big thank you again to Katie and Sheila for taking time out of their schedules to join with us today and provide such useful information. I will send all of the information promised to everyone who participated today. And once again, if you do have further questions after we close, you can direct them toward me at ssshuman@alz.org. And I see lots of thank yous coming in, so we appreciate all those. So everyone, take care, and we will close at this time. Thank you very much.